Okay, well, you guys are probably sensing a theme. Here's our last talk before the break. So we've had sepsis, we've had fluids. That means it's time for vasopressors. So thank you very much, Dr. Griffith, for joining us. And he's going to be talking about vasopressors and septic shock, old friends and new.
Thanks, Catherine. I'm really excited to be able to talk to you all today and talk to you about drugs that probably most of you use very frequently. So I term this talk Old Friends because I'm sure many of you use some of these drugs that I'm going to talk about. But then there's some new data and new drugs that have more recently appeared, and we're going to discuss that as well. For the outline of my talk, we're going to quickly define shock and its causes. I'm glad you've already talked or heard a decent amount of talks about this today. We're going to talk about what goals we're trying to achieve with pressors. And then in part 2, we're going to review the literature for initial vasopressor choices in septic shock. And then we're going to move on and talk about more advanced pressor choices, the new friends that we're making more recently. And I have no disclosures. So what is the definition of shock? Shock at its core really is tissue hypoperfusion. This leads to tissue hypoxia and organ dysfunction. But more often we notice shock on the wards or when patients present by measuring blood pressure. And so oftentimes it's a MAP below 60 or 65 or a decrease of more than 30 from their baseline arterial blood pressure. And we in the MICU, in the medical ICU, see a decent distribution of types of shock, with the majority being septic shock, as you can see here. About 62% of cases in the medical ICUs are thought to be distributive and septic related, whereas about 4% are non-septic distributive. And then there's a mix of cardiogenic and hypovolemic shock as well, and a small portion of obstructive shock. But I want to remind everyone that a low SVR often can contribute to non-septic shock states. So even in cardiogenic shock, you can see a low SVR as well as bleeding. We often have seen the patients that have significant bleeds that need pressor support due to vasodilation. Likewise, cardiomyopathy can complicate sepsis. So depending on how you look with echo and what measure you're actually measuring, more than 50% of patients may have some amount of cardiomyopathy and sepsis. What should our MAP goal be when we're starting pressors? This was first studied in the sepsis-SPAM trial published in the New England Journal in 2014. This was a pretty big trial. It had over 700 patients, and they randomized patients to standard of care. And you'll see here, like we actually see in a lot of studies, that a goal target MAP of 60 to 65 usually results in actually a higher MAP in the 70 to 75 range. And then they had a higher target group that was above 80. And you can see they achieved very good differences in their MAP targets. But there was no difference in mortality between the low target and the high target groups in the all comers. There was a trend towards more renal replacement therapy and chronic hypertension patients in the lower target group. So they had more RRT in the low target group, but there was more AFib in the high target group in all comers. More recently, people have started to be concerned about vasopressor toxicity. And so there was a trial published in JAMA in 2020 called the 65 trial, which randomized over 2,600 patients in the UK and multiple UK ICUs. They were all over the age of 65, and they were randomized to usual care, which, like sepsis-SPAM, usually involves a MAP of kind of 70 to 80. Versus a permissive hypotension group, which had a lower MAP, targeting a MAP of 60 to 65. They did achieve lower pressor use in the permissive hypotension group, and they weaned pressors quicker in the permissive hypotension group. Like sepsis-SPAM, there was no statistically significant difference in mortality. with a p-value of 0.15. And there was a pretty close survival with 41% a mortality rate in the permissive hypotension group and 43% in the usual care group. Interestingly, and probably somewhat confusingly, in patients with chronic hypertension, this was a pre-specified subgroup analysis, over the age of 65, they actually did better with permissive hypotension. So this is very different than what sepsis found, that in all comers, that the renal replacement therapy was actually reduced with increasing your blood pressure. So I think in general, the jury's still out for subgroups that may benefit from different blood pressure targets. For me, I tend to target most people a MAP of 65 or 60 to 65. And if the young patient that has chronic hypertension below the age of 65, I may push the pressors higher if they're not showing signs of a lot of renal dysfunction. What pressors should we choose? Well, I think I wanted to start with this paper published in 2016. There's a lot of variety. And this really shocked me when I saw this, actually, because you get used to what your hospital uses. But in this paper, they found that as a first agent start, only 30.6% of patients in a huge trial of over 580,000 patients, not a trial, a retrospective analysis of a big cohort. Only 30.6 had norepinephrine started as the initial pressor, with a mix of phenylephrine, dopamine, epinephrine, as well as vasopressin as the primary first agent. And really, as a single agent, there was a wide variety of choices as well. And this wasn't based on patient characteristics or even the individual hospital, but more with hospital characteristics overall. This was fairly poorly explained in the paper, but basically the amount of variability was based on kind of various characteristics of hospital and hospital programs. When we're thinking about vasopressors, there's really three main receptors that we're thinking about, and that is the alpha adrenergic receptor, the vasopressin 1 receptor, and the angiotensin 1 receptor. All of those increase calcium flux in the vascular smooth muscle cells and increase contraction, counteracting the vasodilation that's seen with nitric oxide production during inflammation. So what pressors should we use? One of the first trials and the largest trial on pressors when it was published in 2010, the SOAP-2 trial by DeBaker et al., looked at over 800 patients randomized to receive either dopamine or norepinephrine. These patients were in shock with a MAP less than 70, despite at least 1 liter of fluid. And I think one of the strengths of this paper was they enrolled patients very early, within 4 hours of pressor use. And if blood pressure wasn't maintained up to 20 mics per kilogram per min of dopamine or 0.19 mics per kg per min of norepinephrine, then you were allowed open label pressor use. But it should be noted that vasopressin use in this study was very low, only 2 patients in each group, and steroid use was also low, 10% in each group. This was not a statistically significant trial, but it was close. 0.07 was the p-value, with a trend towards improved survival in the norepinephrine group. Interestingly enough, this was a pre-specified subgroup analysis, and the patients who had the largest improvement with norepinephrine being better than dopamine were actually patients in cardiogenic shock over hypovolemic or septic. And subsequent meta-analyses have shown, heavily weighted to this DeBaker trial though, have shown that the number needed to treat with norepinephrine over dopamine can be as low as 9 to see a clinical benefit. Why do we see this clinical benefit? Well, one reason may be a decreased rate of arrhythmias. That was probably the strongest signal in this, and I think why we really changed practice, even though the p-value was negative for this trial in terms of survival. And I think it's pretty convincing that dopamine had about twice as many arrhythmias, including more atrial fibrillation, ventricular tachycardia, and VFib. And so based on this, I think most people have moved away from DOPA, and it's now recommended that norepinephrine be the first-line choice for septic shock. What are some other reasons that norepinephrine may be beneficial? This was actually a really interesting study published in the Blue Journal by Sok et al. In 2020, and they found that norepinephrine actually has fairly strong immune modulatory capabilities. So this is whole blood monocytes in which they gave LPS to the monocytes, and then they gave either increasing doses of norepinephrine or vasopressin. And you can see that norepinephrine actually strongly decreased the release of TNF alpha by the monocytes, while vasopressin had no effect, and increased the amount of the immune suppressive cytokine IL-10, and so really flipped the immune milieu from an inflammatory to an anti-inflammatory immune milieu very quickly. They then did this study in volunteers in which they gave a dose of LPS, and they gave pressor at the same time. And what they found was that in the blood, if you received norepinephrine, your peak TNF-alpha was lower, whereas your peak IL-10 was actually higher. They hypothesized that this may be related to the immunoparalysis that's seen with sepsis, but it's also possible this could be a beneficial effect early on during the hyperinflammatory states of sepsis. So what about our other old friend, vasopressin? Vasopressin is a small peptide that's released by the posterior pituitary gland. It's been found to be deficient in over 33% of late sepsis patients, and there's hypothesized that there's resistance in other patients as well. Vasopressin hits multiple receptors. The V1 receptor results in vasoconstriction, whereas the V2 receptor is mostly in the renal cortex and causes fluid retention in the renal collecting duct. And there is a V3 receptor in the pituitary that causes release of ACTH. And there are other receptors as well. And there's a P2 receptor that vasopressin hits that actually can increase NO production in the pulmonary endothelium, interestingly enough. So there's minimal effects on pulmonary vasculature from vasopressin. The V1 receptor is not highly expressed in the pulmonary vasculature. And there's some data that there's pretty strong data that vasopressin can actually enhance renal perfusion because of its effect, greater effect on the efferent versus the afferent arterioles. So that brings us to the clinical trial data. One of the largest trials was the VAST trial. This was a comparison of norepinephrine alone versus norepinephrine plus vasopressin in over 700 patients with shock in the ICU. The hypothesis was that vasopressin would decrease 28-day mortality. And they had a secondary analysis grouping patients into those with less severe shock at initiation and more severe shock as determined by greater than 15 mics per min of norepinephrine. And their hypothesis was that vasopressin would actually be more effective in the more severe patients that had the higher doses of norepinephrine. Interestingly enough, there was no significant difference in mortality based on p-value, though there was a trend towards improved mortality with vasopressin. And what's really interesting is in the pre-specified subgroup analysis, there was a statistically significant improved 28 and 90-day mortality in the patients with less severe shock. So this went against their initial hypothesis, whereas there wasn't a difference seen in the more severe shock patients. And we'll get to why maybe this was seen in this study. A more recent trial published in JAMA in 2016 actually asked, based on the VAST trial, if vasopressin as the initial pressor would decrease renal failure. This was actually an interesting 2-by-2 design because on the VAST trial, most of the patients who benefited from vasopressin were also on hydrocortisone or steroids. And so they did an interesting 2-by-2 design where patients would get vasopressin or norepinephrine and hydrocortisone or placebo. Their primary outcome was kidney failure-free days, the AKIN3, or death. And they had a very quick time to administration of 3.5 hours. These are our 4 groups. So vasopressin with hydrocortisone, vasopressin with placebo, norepinephrine with hydrocort, and norepinephrine with placebo, all about 100 patients in each group. They did not see a difference in mortality or renal failure days in any of the groups studied. Though what's really interesting is the AKIN3 definition is very broad, right? So it's a creatinine of greater than 3 times baseline, anuria for 12 hours, or renal replacement therapy. It's very binary. So one of these patients could have just had a tripling in their creatinine, whereas another could be dead or on renal replacement therapy, and we don't know the difference. When you look at overall creatinine values, interestingly enough, the patients on vasopressin had a lower creatinine value and had a higher urinary output on vasopressin compared to those on norepinephrine alone. And patients treated with vasopressin were less likely to need what I think is more clinically relevant in the ICU, which is renal replacement therapy at 25% versus 35%. In 2018, in JAMA, there was a large meta-analysis. It was heavily weighted towards the trials that I mentioned, but they did throw in other smaller trials as well. And they found that 68 fewer patients per 1,000 would develop AFib if vasopressin was used compared to norepinephrine alone. There was a trend towards reduced mortality with 45 fewer patients per 1,000. However, this did not hold when only studied with trials with low bias. There was a trend towards reduced renal replacement therapy. This was not statistically significant, but there was a definite trend. And there was definitely more digital ischemia. So 24 patients out of 1,000 had digital ischemia with vasopressin compared to norepinephrine alone. When should we start norepinephrine as our primary pressor? I think earlier may be better. And so this was a trial published in the Blue Journal in 2019. This is a sensor trial. This was a single center trial which randomized patients with suspected infection and hypotension to very early Levophed compared to placebo. And the median time from norepinephrine to norepinephrine initiation in the early norepinephrine group was 90 minutes after admission or ED arrival versus 192 minutes in the standard of care group. There was no difference in fluid administration, actually. They got about the same amount of fluid, so there was significantly reduced mortality in this group, though not significant because it was a small phase 2 study. And there was interestingly less cardiogenic pulmonary edema and less arrhythmias in this group. So I think this bears further study, but does kind of hold to the bias that earlier pressors may be better. In addition to starting norepinephrine early, I think it's worth discussing when we should start vasopressin. And this is often what I get asked more often when I'm rounding in the ICU. We've already had the patient on norepinephrine from the ER. When should we add vasopressin? And I think my practice has changed over time. And this study has kind of confirmed some of my biases. So I have added this trial, or not really a trial. This was published in JAMA in 2025. And basically, it wasn't a randomized trial, but it was using artificial intelligence. So it used a reinforcement learning rule of vasopressin use in a cohort of over 3,000 patients in the UCSF ICUs. And what they did was the reinforcement learning rule was use vasopressin or not to improve mortality of the patient. Or they had other parameters as well, including decrease of Levophed as a parameter. So that was also thought to be beneficial. But they then went on to, after this reinforcement learning rule was derivated, they went and validated it in a larger cohort of over 10,000 patients from multiple ICU cohorts. And what the reinforcement learning rule found was that it recommended a lot more vasopressin use early compared to what clinicians were doing in the ICU. So here's what clinicians were doing. giving some vasopressin up front, but a large proportion of patients never received vasopressin at all. Whereas here, there was a significantly increased use of vasopressin early based on the AI rule that it would recommend, and many more patients got vasopressin overall. They then went and looked at so the reinforcement rule basically recommended vasopressin in 87% of patients within 4 hours, starting at a lower SOFA score and a lower epinephrine dose of 0.2 mics per kg per min, with a lower serum lactate of 2.5 compared to standard. And when they found concordance, so when the clinician did what the reinforcement rule recommended, this was associated with significantly improved mortality and reduced renal replacement therapy. So you can see that overall here. This was the vasopressin initiated per the reinforcement learning rule, and there was a improved odds ratio for mortality. And then this was if you started vasopressin over 4 of lactate at higher doses of norepinephrine, or after 12 hours of a MAP lower than 65, and you can see that the odds ratio of mortality was significantly increased. So based on that data and based on other data as well, I have started using vasopressin significantly earlier than I have used before, and my trend has been towards using it earlier. Now, when we're using pressors very early and more aggressively, do we need to place central lines in all these patients? And I think the answer is changing over time. We used to, put a lot of central lines in even in the floors at rapid responses when I was a resident, and that's changed significantly. This is, I think this was one of the first studies. This was in the Journal of Hospital Medicine in 2015. This was a one-institution study, and they looked back over a 20-month period when they had 734 patients that received pressors by a peripheral IV. The average time was over 49 hours, and the most common med was norepinephrine. They did have a very strict protocol for these IVs. They had ultrasound confirmation. It was an 18 or 20 gauge above the antecubital fossa, and they had a protocol checking these IVs every 2 hours. There were extravasations in 19 patients. All were given phentolamine and nitropase, but there were no tissue injuries at all that were reported. And so it was thought potentially it would be safe. And I think actually the Clover's trial, which was a fluid trial, did also show that peripheral pressor could be safe as well. So in this trial, there was a liberal versus restrictive fluid protocol. And if the MAP was less than 65 in the restrictive fluid protocol, you would give norepinephrine and additional pressors as needed. And so there was significantly less fluid given to the restricted group and significantly more pressor, up to 59% in the restricted group as well. And only 27% of the restricted group had a central venous catheter placed within the first 72 hours, despite 59% of them getting pressors. Over 500 patients received pressors peripherally in this trial. They had 3 extravasations, but no complications from infusion site extravasations. And practice is changing. So this was a recent JAMA network paper where they did a survey of over 10,000 critical care docs with over 700 responding. They were given cases about what they would choose and how they would choose to administer pressors. And in various cases, the critical care docs chose to do peripheral IVs only. About 25% of respondents said they were comfortable using peripheral IVs throughout the entire case. Others, and this is usually my practice, use peripheral IVs as a bridge. So if you have pressors, you start with peripheral IV. That gives you time then in a controlled fashion to put in a central line, especially on high dose pressors. When my threshold really is, if I were to lose access, would the patient die in a minute? And I think if you're on very high dose pressors, I think you really need to make sure you don't lose access. And then only a very small proportion would just go straight to central line. So this was less than 25%. So to summarize this part of the talk, norepinephrine really is your first line choice. Some people would even argue potentially vasopressin as an initial pressor of choice. I wouldn't use dopamine given the arrhythmia risk. Consider a higher MAP goal in patients less than 65 years of age with chronic hypertension. I usually give that a trial in patients who have poor urine output, but if they don't respond, I don't continue it. I use pressors early, and I add vasopressin very early now, especially anytime I'm reaching for steroids, I reach for vasopressin. But I do think we need to be mindful of digital ischemia. And if I start seeing a lot of modeling or digital ischemia, I will back off the vasopressin or off completely. And I don't delay for a central line. I use a good IV, and then we'll place a central line after that. So what about the new faces that I mentioned? So celepressin was a selective V1 agonist, and it was thought that may be better than vaso, given that vaso also causes some fluid retention. However, this was not confirmed with this clinical trial published in JAMA in 2019. It was a large trial of over 800 patients needing more than 5 micrograms per minute of norepi. And they did not see a difference with celepressin versus placebo in survival or renal replacement therapy, even though there was decrease in the norepinephrine dose. Now, I don't know if that's because of the drug effect, if there was some other target, or vasopressin's mix of receptors is better than celepressin, or if it was the patient population and the amount of norepinephrine that was being used in this trial. What about phenylephrine? I think most of us use phenylephrine time to time, and it's a pure alpha agonist as opposed to Levophed, which is a beta and alpha agonist. And in healthy patients, it decreases cardiac output and can increase LV wall stress. But in septic shock patients, that's probably not true. There is more pronounced hepatic splanchnic vasoconstriction as compared with norepinephrine, but no other big differences in the vasoconstriction portion. And I think I tend to use phenylephrine in specific cases in particular. So aortic stenosis, it can increase coronary perfusion pressure without increased myocardial demand. HOCM, it can increase the surface area for the left ventricular outflow tract, or mitral stenosis, where you increase diastolic filling time. And then there are occasional patients on high doses of Levophed that start going into AFib with RVR that I want to reduce the beta agonism, and I'll switch over to phenylephrine. Phenylephrine is not well studied at all, and it would be nice to see more studies of phenylephrine. This article has definitely given me pause in using it in all comers. This was a analysis of 26 hospitals with a baseline norepinephrine use of greater than 60%. And there was a period of time where there was a norepinephrine shortage. And in these hospitals that decreased norepinephrine use by 20%, which was over 20,000 patients, and they used increased phenylephrine, they saw an increase in mortality in these patients. You were actually 15% more likely to die during quarters of shortage. So they compared when you had norepinephrine to shortage. The reason for this, in my mind, is very unclear. This does not say that norepinephrine is a totally bad drug. It says that not having Levophed or a Levophed shortage is a problem. It may change your clinical practice. It's hard to know. Maybe pressors were used more sparingly. It's hard to know, but I do think this gives me a little bit of pause that phenylephrine may not be the best first-line choice. What about epinephrine? This was an old trial published in Lancet. This was norepinephrine plus dobutamine versus epinephrine alone as the primary initial pressor of choice. They had to have a lactate greater than 2 and 2 signs of tissue hyperperfusion. And there was increased mortality in the epinephrine group versus the norepinephrine plus dobutamine group. And this trial is very interesting as well. This is not a septic shock population. This is a population with cardiogenic shock after acute myocardial infarction, but they tries to randomize patients to either epi or norepi. We don't have a lot of randomized trials with epinephrine. It was a small trial with 57 patients. It was actually stopped early for safety. They found death in 52% of the epinephrine group and 37% in the norepinephrine group, but this was not statistically significant. They stopped the trial because of increased refractory shock in the epinephrine group, but one of their markers for shock was lactate, which we know that epinephrine can increase without increasing tissue hypoperfusion. And so I think this is a little confounded. I wish they had not stopped this trial early, but I do think it's interesting and definitely a signal that epinephrine may not be your best choice in patients with cardiac dysfunction in these acute cases where you increase myocardial demand. And there's also some data that adding dobutamine to most patients, to all comers, is not doesn't improve mortality. And so looking back at early goal-directed therapies, so PROMISE, PROCESS, and ARISE, there was a 8 versus 1% in PROCESS. PROMISE had an 8 versus 1.1%, and ARISE had 15 versus 2.6% using dobutamine. And there was no improvement in mortality in any of these groups with the increased use of dobutamine. There was, in addition, a retrospective study in Finland published in 2013, adding inotropes, and these patients actually did worse compared to patients who didn't get inotropes. And so I think there's some thought that potentially increasing myocardial oxygen demand and beta agonism may be harmful. And so this trial published in JAMA caused a lot of stir in 2013. It was actually a small trial. These patients were on pressors for over 24 hours, and they were started on esmolol if their heart rate was greater than 95 beats per minute after the 24 hours of pressors. They had to be on high-dose norepinephrine to maintain a MAP greater than 65. And 77 patients had esmolol titrated to decrease the heart rate to 80 or per min or less, and then the rest had 94 per min as the average. It should be noted that this was a European trial, and they used this drug called levosimendan, which is a cardiac sensitizer, and that has a lot of effects and was not shown to be beneficial in sepsis. And so there was very high levosimendan groups. There may even be harm to levosimendan. And so this may complicate what we're seeing here. But what they found was a very high mortality rate in the control group of close to 90%, and then a decreased mortality of 67% in this group. And this was a very sick group. They were on high-dose pressors for over 24 hours and had a high heart rate. However, there was a recent meta-analysis in CHEST of 885 patients with open-label treatment of either esmolol or landiolol, and found no difference in mortality. So I think the jury's still out. I'm a little skeptical of this very high mortality rate in these patients and the levosimendan, the fact that most of these patients were on levosimendan. But there is a trial recruiting 340 patients, though I haven't heard about this trial lately, so hopefully they're still recruiting. That leaves us to, are there other ways to reduce kind of beta agonism in other trials? And that leaves us to the Athos 3 trial using angiotensin II. I say recently, but it's been a few years now. And this was published in New England Journal. It was 321 patients with vasodilatory shock. They had to have a cardiac index greater than 2 and an SVO2 greater than 70. And it was thought that they were fluid replete based on CVP greater than 8. They were on more than 0.2 mics per kilogram per min of norepinephrine. Greater than 90% of these patients were on norepinephrine, and greater than 60% were on vaso. So these were sick patients. Burns, ACS, liver failure, mesenteric ischemia, bleeding, neutropenia, and cardiac obstruction were excluded. And they were randomized 1-to-1 to receive human angiotensin versus placebo at titrated doses. The primary outcome was not survival in this trial. It was an increased blood pressure in 3 hours. And so they started angiotensin at 200 nanogram per mil to target an increased MAP of 75 in the first 3 hours. And then basically the other target was titration down of other vasopressors at 48 hours. And so you can see here when you start the angiotensin, it could be titrated up, and they did achieve an increase in MAP in the first 3 hours. And then after that, there was a statistically significant decrease in the use of other pressors with angiotensin. As I said, it wasn't powered to look at survival, though there was a non-statistically significant sort of trend towards improved survival in the angiotensin 2 group. And I think this is interesting. This is a subgroup analysis of the same trial with patients that were on renal replacement therapy. This was published in Critical Care Med. And this demonstrated that if you were on renal replacement therapy, you had significantly improved survival with the initiation of angiotensin 2 compared to placebo. One thing to be aware of is increased rates of DVTs. There is some concern based on this trial. These are small numbers, 3 versus 0, but this did lead to some concern. There's reports that as many as 13% of patients versus 5% for placebo can develop DVTs, although a recent systematic review of observational and randomized trial data was not able to link or refute a link of thromboembolism with angiotensin 2. Interestingly enough, there's a trend towards actually improved cardiac function in these patients. I think there's some concern that we could see a worsening as well. But there was a trend towards actual less cardiac disorder in these patients. So this is just a reminder of the renin-angiotensin-aldosterone system. Angiotensinogen is made by the liver and is cleaved by renin, which is made by the kidney in response to many stimuli, but primarily hypotension and low blood pressure. This cleaves angiotensinogen into angiotensin 1, and then ACE, which is primarily in the lung endothelium, cleaves angiotensin 1 to angiotensin 2. This hits the angiotensin 1 receptor, which causes smooth muscle vasoconstriction, release of aldosterone and ADH. It can also cause inflammation, so it causes immune cells to make inflammatory cytokines. In tissue beds, there are other ACEs, so ACE2 and DPP3, which have the alternative RAS pathway, which form these other angiotensins 1 through 9 or 1 through 7. And these can these can hit these receptors, the AT2R and the MAS-R receptors, to decrease cytokine release, but also decrease vasoconstriction, so cause vasodilation. So blocking these may be a viable pathway as well. And can we choose, since angiotensin is still a relatively expensive drug, can we choose patients who would benefit? There was a study that found that the angiotensin 1 to angiotensin 2 ratio, a higher increased ratio of angiotensin 1 was associated with increased mortality and septic shock, but this is hard to measure. However, renin is actually pretty easy to measure. There are lots of various assays for renin. It's interesting that renin has been inhibited by angiotensin 2. So it's thought to be a marker. Angiotensin 2 feeds back and inhibits release of renin. So it's thought to be a marker. Elevated renin is thought to be a marker of dysregulated RAS pathway. And interestingly enough, the max renin is actually better at predicting ICU mortality than lactate, based on this trial published by Gleason et al. In Critical Care Med in 2019. And the slope of renin, so the improvement of renin or the lack of improvement of renin, for each unit of increase in the slope of renin, the odds of mortality increased tenfold. So renin was better at predicting mortality in both these studies compared to lactate. This trial below looked at patients who might benefit from angiotensin 2. And so they took patients that had below median renin, and this was in the Athos 3 trial, and the renin was measured at time 0. And if you had below median renin, you did not respond. You did not have any benefit to angiotensin 2. Whereas if you had above median renin, so your mortality was worse based on these other trials as well. But if you were given angiotensin 2, you had statistically significant improved mortality. And so maybe renin would be a way to choose the use of angiotensin. This is our MGH protocol. We do use angiotensin II and MGH. You need to be on vasopressin and one of the following pressors, norepinephrine typically greater than 20, and vaso, as well as steroids. And then we start vaso at 5 to 10. That's different than the trial where they started it at 20. And we do titrate every minute up as needed, up to 40. And maybe as high as 80. And then we titrate back down after the first 3 hours of use. We stop it in patients who don't respond. There is some theory that patients on cardiac bypass may actually have bypass the ACE and so have lower angiotensin II levels. And so this was a small trial using angiotensin II and post-op vasoplegia, and they did find a lower rates of need for renal replacement therapy and lower AKI overall. Though there was high AKI early, there was less overall in these patients that got angiotensin, and there's a trial ongoing on post-op vasoplegia. Nitric oxide inhibition did not work. It increased cardiac disorder. And methylene blue in this trial was given and decreased pressor use, but did not change overall mortality. And so we do use it as kind of a rescue. I tend to use hydroxycobalamin because with methylene blue, you risk serotonin syndrome, G6PD, and it can exacerbate pulmonary hypertension. We do use midodrine occasionally in patients to get them out of the ICU. This was a trial that suggested maybe a decreased length of stay, though in a randomized trial in the SICU, there was no difference. And so maybe it's a different patient population, but maybe midodrine doesn't really get you out of the ICU any faster. And finally, I wanted to end with this, the idea that this was published in Critical Care in 2023, and it's this idea that maybe we need to use multiple pressors early instead of using sequential pressors. And I think this idea is really attractive and unique. It's the idea that a multimodal approach, potentially with norepinephrine, vaso, and angiotensin II, using all these pressors early, will increase the amount of perfusion and prevent this pathway to progressive multi-organ failure and refractory shock that we often see in the ICU. So I think pressors, there's a really exciting time. How should we titrate pressors? To what MACL should we use? I still think this is a question. Should we use a multi-drug pressor regimen initially and early on in the course? And are there biomarkers such as renin, which would suggest what biomarkers we will use? Does angiotensin truly improve mortality? I think we still need that study. And should we use beta blockers or phenylephrine in selected patients? Let's stay tuned. Thanks a lot.